Hi, it's Zoe Brooks here again. So let's continue now, but let's bring this into reality. Look at a glucose test where we've set the medical goal at the Diabetes Association standard that any glucose result you report should be within 10% of its true value. What we're looking at here is not Quality Optimizer. This is one of Prof-Zoe's QC verifiers that let people explore and see how the QC numbers interact and how quality control determines patient risk. That's the question we're trying to answer. Is patient risk acceptable? Yes, no, or do I need to improve this method? The first trick is to say what is acceptable. You first want to ask yourself, what is the potential harm and clinical cost of a medically invalid result on average? If I send out a glucose result that is more than 10% from its true value, what's the odds that something really bad is going to happen? It may not 99 times out of 100, but that 100th time something really significant may happen. So you need to weigh with this test, how many people am I willing to see fail? What is the maximum number of results that can fail medical goals and possibly cause delayed or incorrect patient diagnosis or treatment before you stop reporting, alert clinicians to potentially misleading results reported, and verify acceptable risk levels before you report any more patient results? In this case, I very arbitrarily set that number at 50. That number would typically be defined by the medical director and the medical advisory staff. I'm allowed 50 medically misleading results before I have to stop. How many patients are at risk right now of medically invalid results? 0. This is a very good method. At this time, while it remains stable, it is reporting 0 medically invalid results. The analytical process quality at this point in time, yes, is acceptable. The next question is the QC effectiveness acceptable? In order to determine if QC effectiveness is acceptable, what we do is simulate a change that makes 5% fail. So right now, 0% are failing. What would happen if 5% failed? How soon would you detect that error, and how many patients would be reported before you stop reporting? How many patients would be exposed to a medically invalid result? 24. That's if 5% of the results reported after a clinical failure receive those medically invalid results. That's 5% of the total of 484 patients who would have been reported. Where does that number come from? That is a factor of the 2 variables that actually drive the number of patients at risk. The runs to reject, the number of runs it takes your quality control to detect a clinically significant error, and the patients per run. By controlling those 2 variables, you can control the number of patients at risk, and you can maintain acceptable risk levels. We're going to see how. In this instance, there was only 1 run to the reject and 484 patients per QC run in between each QC sample. That is based on a patient volume per month of 30,000, so this is a high volume lab. We're doing 1,000 patients a day. They're running their QC essentially twice a day, 62 times in the month. And if you want to add a clinical cost to this, you can say if it costs $20 on average for each medically invalid result reported, then the maximum clinical cost of failure is $968. We charge $1 for each of these 484 poor folks exposed to the possibility of risk, and then we charge $20 for each person who actually received a bad result. That's the process it's applying. Now let's see what happens if we go to a couple of different scenarios. This is Lab B, Instrument 3. Is patient risk acceptable at this time? Well, yes it is, but notice how the other method, and in fact every other glucose method, had 0% results and 0 patients wrong in a month. This one has 5. Something going on there, but you know that without having to go through any statistics. Is the analytical process quality acceptable now? Yes. Is the QC process acceptable? Oh my goodness, what went on here? If this method failed, 420 patients would be exposed to medically invalid results. That's from the 8,400 reported, because it would take 14 runs at 600 patients per run to detect a medically significant error in this lab. How does that happen? That happens with ineffective quality control design. What can you do about it? If you change just the QC design for this method, you can reduce the runs to reject from 14 to 1. Now you have 30 patients exposed to risk. By redesigning the QC process, if the method failed, you would expose now 30 patients to risk instead of 420, simply by tweaking your QC process.